Hello everybody. As you can see from the title, this presentation is about the integration of palliative care in cancer, vs. the integration of palliative care in chronic heart failure and chronic or obstructive pulmonary disease in Europe. I will start with this presentation with the definition, the working definition that we developed in with the InSup-C group, but since already Jeroen and Carlos have presented it to you, I will move forward to the motivation for this study. The motivation for this study stems from the two systematic reviews that our group published recently this year for that quantify the level of integration of palliative care in patients with cancer and chronic heart failure and COPD in Europe. What we actually did is that we searched for guidelines and pathways that advise the implementation of integrated palliative care in both groups. For the purpose of these studies, we define guidelines as systematically developed statements to assist practitioners in patients' decisions about appropriate health care and specific clinical circumstances. They can be national, international, or local. As such, they are often used as a means to reduce variations in treatments within healthcare systems, to develop hospital-tailored protocols, to educate students, and to assist insurance. A care pathway is defined as a complex intervention for mutual decision-making and organization of care processes for a well-defined group of patients during a well-defined period. A pathway may use guidelines to provide clinical care. Now, the aim of this study is actually to compare these two systematic reviews and to quantitatively analyze the levels of integration of palliative care between the guidelines and pathways of cancer and CHF COPD in Europe. In order to do so, in order to measure the level of integration of palliative care in the content of the guidelines and pathways, we employed an 11 criteria tool, which has the name IPC criteria. This tool was developed based on the study of Emmanuel et al. In 2004. What we actually did with this tool is that we assigned a score to each guideline and pathway based on the number of criteria that they fulfilled. It is a 12-Likert scale, where a 0 score stands for no integration, and 11 stands for utmost integration. It is important to also note at this point that the IPC criteria constitute quality indicators that they measure the level of integration in the content of guidelines and pathways. However, they do not provide any information about the efficacy of the guidelines and pathways in the implementation in the clinical practice. As this tool is so critical for our search, let me go through the criteria one by one. So it includes recommendations or discussions of illness limitations and prognosis, recommendations of holistic patient assessments, and recommendations on when to apply these holistic assessments, recommendations on when to initiate palliative care in general, and assessments for patients' goals and continuation of goal adjustment throughout the disease trajectory, recommendations in order for interventions that aim to reduce suffering and advance care planning, recommendations of involving a palliative care team, and also for last hours of living, and finally recommendations on grief and bereavement care. For the quality assessment of the evidence, we use this 4-Likert scale, where guidelines and pathways that were developed based on both systematic reviews and consensus methods were considered of high quality evidence. Those that they were based only on systematic reviews were considered of medium quality. Those developed only in consensus methods were considered of low quality. And those that they were developed, they didn't mention any information for the way they were developed, and they were unclear. They were characterized as guidelines or pathways of very low quality. Now, for the statistical analysis, what we did is that we used a combination of tools, including the equality of means, analysis of variance, correlation analysis, and standard descriptive statistics. And we wanted to be careful which tools we chose, because we wanted to capture the ordinal character of the variables. Now, moving on to the results. In this table, what you can see is that is the number that we included for for guidelines and pathways of cancer and CHF COPD, their distribution according to their publication dates, and also their geographical distribution. From this table, we can make two quick observations. First, that the number of cancer guidelines is much more than the ones of CHF COPD, which is not something really surprising since palliative care was first initiated in cancer, and it was then applied to other chronic diseases. And the second point is that you can see the geographical distribution, that the majority of the guidelines and the pathways, they originate from the UK. This is not also not surprising because palliative care was born in UK. So it's more advanced there. Now, moving forward, in this table, you can see the relative frequencies of the IPC scores ranging from 0 to 11. In order to check if there were any differences in the medians, we had to run a manual test, which showed that there was no statistical significance between the IPC criteria. This means that the level of integration for cancer and COPD in Europe is actually statistically the same. And the levels for both groups were moderate, because their median scores were 5 and 7. However, what we need to notice is that even though palliative care, integrated palliative care started later for CHF and COPD, it has caught up with the one for cancer. Now, with the equality of means in mind, we can look what IPC criteria, the guidelines, and the pathways fulfilled. And here we can see the relevant frequencies of the satisfaction of the IPC criteria. And it is very interesting to observe that both groups pay insufficient care, attention to the treatment care, even though its importance is very well elaborated in the literature. It's also interesting to see that even though both groups pay specific attention to the holistic approach, the timing of when to apply a holistic assessment is not usually clarified. Aspects that they are highlighted are usually the illness prognosis and prognostication, the interventions for suffering reduction, and also involvement of palliative care team. Other aspects like the referral criteria, the patient goals, and the advanced care planning are not very well elaborated. And you can see also that the goals adjustment throughout the disease trajectory is not very well elaborated. And also the last hours of life. Now, since the integrated palliative care requires the integration of palliative care alongside the treatment in the disease trajectory, it is interesting to see what do guidelines and pathways perceive as the right point to initiate integration of palliative care. This is usually referred as referral criteria. And as you can see from this graph, the most favorable referral criterion is the absence of referral criteria, which means that the majority of the guidelines and pathways, they didn't give any information about when palliative care should be initiated. Also, among the rest of the referral criteria that they were presented for both groups, we see that there doesn't seem to exist a convergence of opinions. Now, in general, the referral criteria, as it was discussed before, it's a contentious topic. For example, the TQ trajectory for CHF and COPD is very complex, consisting of worsening and of partial recovery, and also sudden death is not an unusual phenomenon. On the other hand, concerning cancer, even though the disease trajectory in cancer is in principle more predictable, there are several studies that they do complain that the referral criteria that they are available right now are either too general or they are very hard to realize in the clinical practice. So even if we ignore this ongoing discussion, what we can see from this table is that very little focus is placed on the early integration of palliative care. In this table, you can also see the performance of the guidelines and pathways concerning the equality, the way they were developed. And even though in both groups more than half of the guidelines and the pathways were developed with high standards, so they were developed based both on systematic reviews and consensus methods. We see that there is still a lot of space for improvement for the way that we make guidelines and pathways. What we also did in this study is that we tried to see if there is any correlation between the IPC score, the quality of evidence, and also the year of publication. And the results that we got were negative. So no statistical significant correlation was observed, which means that the level of palliative care integration with both cancer and CHF COPD doesn't seem to depend on the timing or the setting of guidelines and pathways. This is not a very encouraging finding, as we would like to see that the levels of integration increase through time. Now, for the limitations of this study, since there is no globally accepted measurement tool for the measurement of integrated palliative care in the content of guidelines and pathways, we had to employ our ad hoc tool with all its strengths and its weaknesses. And also, this study carries automatically all the limitations of the previous two systematic reviews, for example, the specific search strategy or the linguistic restrictions, etc. Let me conclude this talk by summarizing the main points. So the levels of integration of palliative care in patients with cancer and CHF COPD are statistically the same. And even though palliative care in CHF and COPD has a shorter history, it has done considerable progress regarding the integration in comparison to cancer. On the other hand, our analysis also showed that the levels of integration of palliative care are moderate for both groups, for both cancer and CHF COPD, and that it didn't seem to depend on the ways and the timing of the development of the guidelines and pathways. So what we would actually recommend is that existing guidelines and pathways should be updated and revised accordingly so we can increase this moderate level of integration. Thank you.